Hello, everyone. Can you hear me? Great. Hello, everyone. I've received confirmation that you can hear me online and hear me in the room. So I think we will get started. So I would, first of all, I'd like to thank the National Liver Foundation of Bangladesh for bringing us all together today. My name is Jessica Hicks, and I'm Head of Programs at the World Hepatitis Alliance. The World Hepatitis Alliance is an international umbrella organization with over 300 members in over 100 countries, including the National Liver Foundation of Bangladesh. And along with our members, we work to drive action to improve the lives of the 325 million people globally who are living with viral hepatitis. Sorry, I've just heard that they can't hear me in the room. Zunaid, can you hear me now?
Yes.
You can hear me?
Hello.
Hi, Zunaid. Can you hear us from London?
Yes, we can hear you now.
Great. Okay, wonderful. So I'll start.
Now we can start, I think.
Great.
Okay.
So, well, thank you very much to Zunaid, Professor Ali, and the National Liver Foundation of Bangladesh for bringing us all together. My name is Jessica Hicks, and I am Head of Programs at the World Hepatitis Alliance. The World Hepatitis Alliance is an international umbrella organization with over 300 members in over 100 countries, including the National Liver Foundation of Bangladesh. And along with our members, we work to drive action to improve the lives of the 325 million people globally who are living with viral hepatitis. And I'm delighted to be at this meeting, which has come about as the result of the inspirational personal story that Muslima Keita submitted to the Global Hepatitis Open Call contest that we organized along with the London School of Hygiene and Tropical Medicine. And it is great that as a result of sharing her experience of viral hepatitis, we're able to bring such an esteemed group of people together to discuss hepatitis elimination in Bangladesh. And along with hearing Muslima's story today, we will also hear from the following speakers. So Professor Muhammad Ali, the founder of the National Liver Foundation of Bangladesh. We'll hear from Annie, Dan, and Joe, who are joining me online and are our partners at the London School of Hygiene and Tropical Medicine. We will be hearing from Professor Dr. MD Shahanul Alam, the professor of the Department of Hepatology and General Secretary at the Hepatology Society of Dhaka, Bangladesh. Professor Farooq Ahmed, Director of the Sheikh Russell Gastro Liver Research Institute and Hospital, and General Secretary of the Bangladesh Gastroenterology Society. Dr. Gholam Azam, Associate Professor, Department of Gastrointestinal Hepatobiliary and Pancreatic Disorders, and at Burdham General Hospital, Dhaka. Dr. Farooq Ahmed, Head of the Department of Hepatology, Dhaka Medical College and Hospital. Professor Syed Alamgir Safwa, Professor of Department of Gastroenterology, Jalalabad Raghib Rabia Medical College in Bangladesh. Professor M. Anizur Rahman, former Professor and Head Department of Gastrointestinal Hepatobiliary and Pancreatic Disorders at Burdham General Hospital, and Joint General Secretary, the National Liver Foundation of Bangladesh. Professor M.D. Abu Saeed, former Head Department of Medicine at Chittagong Medical College and Vice President of the Hepatology Society, Dhaka, Bangladesh. Professor Solimer Rahman, the former Professor of Hepatology, Bangabandhu Sheikh Mujib Medical University and President, Association for the Study of Liver Diseases. Major General Rabiul Hussain, former Director General of Medical Services, and Dr. Afsana Alamgir Khan, who is the Assistant Director at Communicable Disease Control, the Director General of Health Services at the Ministry of Health and Family Welfare. And we very much thank you for joining us today, Dr. Khan, and hope you enjoy the meeting. We will also hear from Tasmia Noor, who's the President of the Bangladesh Medical Student Society, Arifin Rahman Humel is the co-founder and president of the Youth Club of Bangladesh. Alongside me today is my colleague Cynthia from the World Hepatitis Alliance. So I know we have a packed agenda. So without any further ado, I will hand over to Professor Muhammad Ali for the welcome address.
Good morning and good afternoon to everybody. I'd like to welcome the initiative of World Hepatitis Alliance and London School of Hygiene and Tropical Medicine for initiating the Global Hep Contest meeting and on what can be done to eliminate viral hepatitis in Bangladesh. Globally, we know that about 354 million are affected by hepatitis B and C, which causes about 1.1 million deaths annually. And every 30 seconds, there is one death occurs. And most important, there's 80% of liver cancer is caused by the hepatitis B and C. And this liver cancer is the third leading cause of deaths in the world. Elimination 2030 is the dynamic agenda of WHO and estimated to save 7.1 million lives by 2030. In Bangladesh, DGL Service Bulletin published in 2019 showed that Hep B estimated to be 5.5% and hepatitis C 0.6%. 10 million people living with viral hepatitis in Bangladesh. 20,000 deaths occurs from the viral hepatitis causes in Bangladesh. And also liver cancer is the third leading cause of deaths in Bangladesh, like other countries of the world. Activities of the DG Health is aimed to reducing 90% of the viral hepatitis related mortality by 2030 in Bangladesh. I'm very pleased to announce you that Honorable Prime Minister of Bangladesh, in her available message of World Hepatitis Day 2021, expressed that Bangladesh is working to control viral hepatitis along with other diseases by 2030 to fulfill the global agenda for fulfillment of 2030 elimination. Today, we are going to address the core interventional areas of elimination 2030 goals in Bangladesh, as given by the WHO guideline distinguished speakers from Bangladesh who are already engaged in the fields of viral hepatitis, control and treatment, will express their valued opinion in this field, which will be a great help to fulfill elimination 2030 goals in Bangladesh. I also welcome Dr. Afsana Alamgir Khan, Assistant Director, CDC Bangladesh, has also joined this program. We also welcome members of the Medical Student Society of Bangladesh and the Youth Group of Bangladesh, which are working in this viral hepatitis control studies in Bangladesh. They are also present here. I'm very happy to announce that one of our recipient of Zakat Fund beneficiary, Mrs. Muslima Kader Bidi, has also joined us in this gathering, and she is one of the 202 recipients of beneficiaries of the Zakat Fund. So again, I like to thank everybody, and let us start this program. Thank you, everybody.
Thank you very much, Professor Ali. And I will now pass over to Annie from the London School of Hygiene and Tropical Medicine to give us an overview of the Global Hepatitis Open Call.
Thank you, Jessica. At this point, I'll share my screen. Okay, thanks so much.
And it might be good, just can we confirm that they can see the screen?
Zunaid may be able to share on that. Are people able to see the slides being projected?
Just getting clarity on that.
Okay.
Yes, please go ahead.
Thank you very much. So hello everyone, my name is Ine Pokri and I work as a researcher at the London School of Hygiene and Tropical Medicine. And I'll take the next few minutes to give an overview of our crowdsourcing open call to expand public engagement and advocacy in chronic viral hepatitis. And just before I go into the details of the open call, I'd like to share very briefly an overview of the crowdsourcing concept. So crowdsourcing has been defined as having a large group solve a problem and then sharing the solutions widely with the public. And this could be in different formats. So your open challenge contests are one form or one tool of crowdsourcing, which was what we did for this project. So you may want to ask, why do we use crowdsourcing? Well, first and importantly, it incorporates the public opinion. So it has very strong aspect of public engagement, as the name implies, sourcing ideas, sourcing innovations from the public. And secondly, there is some sort of echo. Okay. Secondly, it allows for more socially and culturally inclusive solutions, because at this point, you're soliciting ideas and solutions outside of your normal research project team or research institution. And also it leads to more innovative ideas, contributions, and solutions. So still on crowdsourcing, we have identified 6 key stages when implementing a crowdsourcing open call. So first and foremost, you want to select and identify crowdsourcing as your desired or chosen methods to implement or execute your project. Once you have that decision finalized, you then move on to identifying and constituting an advisory group or a steering committee. What this does really is that they finalize the details of the open call and also provide feedback and guidance at different stages of the crowdsourcing open call. Once the details of the call is finalized, you want to move to the next step, which is launching the campaign. At this stage, you want to engage the community, you want to promote, advertise the open call so people can actually submit and be a part of the open call. Once you reach the deadline, when you close the call, you then want to collect all of your entries, all of the submissions, review and evaluate the quality and content. And that's done in the judging phase. And through this procedure, you're able to identify some of the high quality and more robust submissions, which leads you to the 5th stage, where you recognize people who have actually submitted quality entries as finalists. And this would be based on a predetermined criteria or a cutoff mark. And at the end of the day, you definitely want to implement the solutions and share the ideas being generated. So these are the main stages in implementing a crowdsourcing open call. So moving to the specific call on hepatitis we conducted, the main purpose really was to solicit stories relating to lived experiences or advocacy experiences with viral hepatitis. And we were interested in personal stories, family stories about living with the viral hepatitis, or any experiences of advocacy. And for this call, we accepted submissions in form of images, videos, audio files, some infographics, and plain written texts. And we particularly encouraged people from the Asian and African regions to submit their story, given the high burden of viral hepatitis within these continents. In terms of distribution, we collaborated with the World Hepatitis Alliance and all of its member community-based organizations to sort of disseminate and promote the call widely. So at the end of the open call, we received a total of 119 submissions. And after initial screening, we had 85 of these submissions eligible to go into the stage of reviews and judging. And after judging, we had 29 submissions qualify as finalists. And for this open call and many others, we defined finalists as entries that were able to achieve a mean score of 7 and above. So that's 7 out of 10, which is sort of a high quality, high ranking submissions. And just picture to my left, you could see sort of like the distribution in terms of participation across different continents. That's where we received submissions and entries from. So looking closely at the characteristics of our submission and participation in terms of people who participated, we had slightly more females compared to males, and almost half of our participants had a lived experience with viral hepatitis. And most of them confirmed they had a family or a friend who also had a lived experience with viral hepatitis. And in terms of the entries itself, majority of the submissions were in English language. However, we received submissions in Chinese, French, Arabic, and Spanish. And in terms of the formats, almost half of the submissions were text, written narratives. We had like a third of the submissions coming in form of images or infographics, and few other entries were audio and video files. Now, looking specifically at the submission from Bangladesh, we received 3 submissions from Bangladesh. Interestingly, all of these were ranked as finalists, having achieved a mean total score of greater than 7. In terms of the format, 2 of the submissions were videos and we had 1 text. And some of the submissions actually acknowledged the impact and input of the National Liver Foundation of Bangladesh in their stories, particularly in the area of testing and treatment. And from these submissions, we've been able to identify some key messages and key issues for taking the viral hepatitis agenda forward in Bangladesh. And I'll be sharing a bit more on this. Now we're going to listen to a video from one of our finalists to the open call as well, before we go into some of the details from the Bangladesh submissions.
রক্ত দিতে গিয়ে তখন জানতে পারলাম যে হেপাটাইটিস বি না হয়নি চাদুকার যে অডিটোরিয়াম ওটাতে একটা হয় লিভার ফাউন্ডেশনের ওইখানে যাই ওষুধ পাচ্ছে 2 বছর প্রায় একবার নেগেটিভ আসছে ডিএনএ তো 6 মাস বন্ধ রাখার পর আবার হাই পজিটিভ হয়ে গেছে এখন আবার ওষুধ চলতেছে অন্য আরেকটা আমার পরিবারের আরো মানে আমার মা বোন ওনাদের পজিটিভ, কিন্তু চিকিৎসা নিতে পারছে না এখন। ওনাদের আমার ধরা পড়ার পর মানে সবাইকে টেস্ট করাই, স্ক্রিনিং টেস্টটা করাই। এই ভাইরাস সম্পর্কে জাস্ট ধারণা আছে, কিন্তু এটার কনসিকুয়েন্স সম্পর্কে নেই বললেই চলে, কোনো মানে ম্যাক্সিমামেরই নেই। আমি এরকম কাজে সবসময় ইচ্ছুক। আমি অলরেডি রাজশাহী ইউনিভার্সিটির বিভিন্ন অর্গানাইজেশনে যুক্ত। কিছু প্রবলেম দেখা দেয়, যেমন হেপাটাইটিস বি, যখন আমি ফ্রিকুয়েন্টলি বলি যে হ্যাঁ আমার হেপাটাইটিস বি আছে, আমার ব্রাশ টাচ বা এগুলি ইউজ করিস না তোরা, দেখা গেল যে আমার কিছু টাচ করা জিনিস ওরা খাবে না, বা এরকম মানে একটা নেগলেন্সিভ ভাব চলে আসে। তারপর যখন দেখলাম যে ওরা জিনিসটাকে ভালোভাবে নিচ্ছে না, মানে খুবই খারাপ ভাবে দেখতেছে, লাইক HIV, তারপর আমি খুব একটা বলি না। জাস্ট যখন যে জিনিসগুলি মানে একদম ইউজ করাই যাবে না, ব্রাশ বা এই ধরনের, তখন আমি নিষেধ করি যে এটা করিস না। আসলে তারা খুবই অসচেতন। যেমন বাংলাদেশে গভর্নমেন্ট জবেই সবাই BCS এর প্রিপারেশন নিচ্ছে, আমি কনফিউশনে ভুগতেছি আসলে নিব কি নিব না। হেপাটাইটিস বি হলেই আউট। তো অথচ 80% কিন্তু যারা ক্যারি করে ইনঅ্যাক্টিভ মানে DNA যাদের, তারা কিন্তু কোনো প্রবলেম ক্রিয়েট করে না। মানে যাদের হেপাটাইটিস বি তারা ওই ফুড প্রোডাকশনের যারা আছে এইসব ক্ষেত্রে মানে না যাওয়াটাই বেটার, বা বিদেশে এটা যেতে দেয় না। অন্যান্য সব সেক্টরে সরকারি ভাবে ঢুকতে পারবে, তো বাংলাদেশে এটা হচ্ছে না। অবশ্যই তাকে বলবো যে ডক্টরের পরামর্শ নিতে, নিয়মিত ট্রিটমেন্ট করতে। 95%ই তো ফলো আপের ভিতর থাকলে কোনো সমস্যা হয় না। ইভেন 100 ইয়ার্সও তারা বেঁচে থাকতে পারে।
Oops. Yes, so following on from that and some of the other submissions from Bangladesh, we've been able to pull together some key messages, which includes the fact that there's still poor knowledge of the hepatitis status for those in the area, and reduced awareness on testing and treatment options available for viral hepatitis. There's still a huge burden around stigma and discrimination for people living with hepatitis, and then some misinformation around the spread and contacting of viral hepatitis. There's also a huge gap in the role for governments and advocacy around hepatitis services delivery, and also the need for supportive policies, and in some instances, the hepatitis C and HIV co-infection rates. So looking deeply at some of the submissions that speak to these messages, one of our submissions actually stated that 9 out of 10 people do not know about the existence of both viruses in their body, and they suffer silently, transmitting the viruses to other members of the family. So there is that need for more knowledge and awareness, and there's the platform that's been in for a while now, the Hepatitis Awareness Month, and action for other advocates and CBOs to sort of raise awareness, and there is need for more of this. And then stigma and discrimination was also highlighted, and some of our submissions identified healthcare professional, a dentist, saying, I do not want to provide care because you would infect me. And then I was also invited to the director's office, where he scolded me for spreading the disease to others. The company also would not hire people living with hepatitis, and the contract, the job employment, was actually terminated. A lot of people still feel embarrassed having tested positive to hepatitis. And then the role of government obviously cannot be overemphasized. There is still that need for supportive policies, especially for people living with hepatitis in different areas, particularly in the area of employment, job acquisition. So another submission stated that I am still unemployed and I feel hopeless knowing that any pharmaceutical company will not hire me based on my hepatitis status. So there's still a lot of role for the government with regards to addressing hepatitis. So in all of these, some implications and next steps for hepatitis in Bangladesh's setting would be for advocacy really to target some of these key points, including stigma and discrimination, seeing how those can be reduced, and then increasing knowledge and awareness about the disease, hepatitis services, and allocation of care. And then there's also the need for partnership with more CBOs to sort of enhance hepatitis advocacy and increase coverage with hepatitis services. Also, there's need for further dissemination of the finalist messages, both locally, internationally, just to sort of spur hepatitis awareness within this region. Actually, 10 submissions to this open call have been recognized and are now officially published on the NoHep website. These are part of the finalist cases, and the link can be put in the chat box and shared later to all of you, so you can actually have access to these submissions. And then generally just creating an environment for sharing hepatitis stories and connecting hepatitis activists, both locally and globally. Before I end, I would like to say a very big thank you to the World Hepatitis Alliance, the Hepatitis Fund funding the project, and then also to the National Liver Foundation of Bangladesh for the great and amazing work you're doing. We would also like to acknowledge all the members of our steering committee for the open call, our volunteer judges, everyone that participated in the open call, and indeed our finalists. Thank you too for joining us today, and I'll stop here, stop sharing my screen. Over to you, Jessica.
Great. Thank you very much, Annie. And so now we're going to see another video of the finalists, Melissa. And so I'm just going to share my screen. I hope everyone can see and hear this.
2013 সালের সেপ্টেম্বর মাসে আমার মেয়ে গলায় টিউমার হয়েছে, এটা সুরদ্দি হসপিটালে অপারেশন করতে এসে তখন রক্ত দিতে হবে, তো ওর ও পজিটিভ আমারও পজিটিভ। আমি তখন রক্ত দিতে গেছি, আমার রক্ত ডাক্তারে নেয়নি, বলে যে আপনার রক্ততে সমস্যা আছে। ওনারা বলতেছে যে আপনি এই ভাইরাসটা কীভাবে আসছে, স্যার এটা কী ভাইরাস আমি জানি না, তো বলছে এটা একটা খুব খারাপ ভাইরাস, এটা আপনি কীভাবে হলো, কোনো অপারেশন হয়েছে নাকি? হ্যাঁ, আমার ছেলেটা ঢাকা মেডিকেলে সিজার করে হয়েছে, তখন আমার একলামশিয়া উঠে আমার ব্লাড নেমে গেছিলো শরীরে, তখন 7 ব্যাগ রক্ত আমার বড়া হয়েছে। আমার ভাইয়েরও ভিসা হয় নাই, আমার ভাই যেতে চাইছিল, কিন্তু ওই ব্লাড টেস্ট করানোর পরে ওর সমস্যাটা ধরার পরে ওর ক্যান্সেল করে দিয়েছে। খুবই চিন্তিত ছিল, আবার কিছু কিছু ছোঁয়াছুঁই ভাবছিল ওরা, তারপরে অনেকটাই আমাকে বলছিল যে একটু বাইসা চলো, এটা একটা ব্যয়বহুল ট্রিটমেন্ট, কিন্তু আমার পক্ষে এটা কিছুতেই সম্ভব ছিল না, কারণ আমার হাজব্যান্ড অসুস্থ, প্যারালাইজ। ও 2013 সালে আমার রোগটা যখন ধরা পড়ছে তখন থেকে বন্টন ওরা বলছিল যে তোমার জিনিসগুলো আলাদা করে রাখবা, কাপড় চোপড়, খাবার, মগ, গ্লাস এগুলা। এরপর আমি ডাক্তারের কাছে গিয়ে জিজ্ঞেস করছি, ডাক্তার বলছে যে না, এটা কোনো ছোঁয়াছুঁই রোগ না। আল্লাহর একটা উসিলা, আমার মেয়ের একটা অপারেশন লাগছিল, ওই উসিলা আমি জানতে পারছি না, আমিও জানতাম না। অনেকেই আমারও বলছিল যে হোমিওপ্যাথিক ওষুধে খরচও কম, এটা খেলে সেরে যাবে, মালা পরা, তারপরে ডাব পড়া, হাত ধোয়া, এইগুলা করলেই সেরে যায়। আমার ফ্যামিলিতে আরও 2 জনকে আমি জানতে পারতেছি হ্যাপাটাইটিস বি হয়েছে, মানে ওরা বিদেশ গেছিল, বিদেশ থেকে চলে আসছে হ্যাপাটাইটিস বি ভাইরাস ধরার পর। তো এই রোগটা আমি যখন জানতে পারছি তখন আমার কাছে মানে খুব খারাপই লাগছে, এবং মানুষে খালি মানে বলতো যে এই রোগের কোনো ট্রিটমেন্ট নাই, এটা মৃত্যু অপরিহার্য। তো এটা বলার পরে আমার খুব খারাপ লাগছিল, আল্লাহ যখন নিয়ে যায় নিয়ে যাবে, কিন্তু যখন জানতে পারলাম যে এটা ট্রিটমেন্ট আছে, আর এই লিভার ফাউন্ডেশন থেকে আমাকে যে ওষুধটা দেওয়া আছে এতে আমি ভালো হয়, আমি নিজেই উপকৃত। আর এরকম একটা ওষুধ যে তৈরি হয়েছে আর মানুষ যে খেয়ে ভালো হইতেছে, এটা অবিশ্বাস্য। ওষুধ পাইছি, ওষুধ পেয়ে আল্লাহর রহমত, আপনাদের উসিলা আমি এখন সুস্থ। থ্যাংক ইউ লিভার ফাউন্ডেশন, আমার জীবন আল্লাহর উসিলা, আপনাদের দয়া আমি এখনো বেঁচে আছি। আল্লাহ যেন আমার মতো আর অনেক মানুষে এরকম বাঁচায় আপনাদের দয়ার উপরে।
Great. Thank you very much, Melissa. I think on behalf of us all, I want to say thank you for sharing your story. And I believe you're in the room with us today. Great. Well, thank you again, Melissa. Musliba, for sharing your story. It's really very much appreciated. So now we'll move on. We have a number of presentations, and I would ask all our speakers to please keep to the 5 minutes that they've been allocated. And so now I'd like to welcome Professor Dr. MD Shahanul Alam to speak on viral hepatitis, the Bangladesh perspective.
Honorable Chairman, learned speaker from home and abroad, and distinguished participant, very good afternoon. I am very much delighted to be here on the Global Health Contest meeting on the topic, what can be done to eliminate hepatitis B in Bangladesh. My duty is to share the information about viral hepatitis Bangladesh perspective. Everybody knows viral hepatitis B and C major health challenges affecting 325 million people globally. They are root cause of liver cancer, leading to 1.35 million deaths every year. The main stage of elimination of hepatitis B is to find the missing million. The definition of elimination is 90% reduction of new cases and 65% reduction of death by 2030. In our country, commonest route of transmission of Hep B is from mother to child transmission during the childhood. And other route of transmission of Hep B and Hep C are unseen blood and blood product transmission, medical or dental intervention without adequate sterilization of equipment, realistic injury in healthcare settings, sharing equipment for infecting the others. Hepatitis B in Bangladesh context, in Bangladesh, 5.3 deaths per 100,000 population are due to Hep B. Hep B is responsible for 30% cases of acute hepatitis, 75% cases of chronic hepatitis, 60% cases of liver cirrhosis, and 65% cases of hepatocellular carcinoma. Hepatitis B prevalence is estimated to range in between 2 and 7% in our country. But after introduction of hepatitis B vaccine in the EPI, yielded positive outcome by reducing the Hep B infection. From the past to recent, Hep B was highest prevalence was in 1984. That was about 15.4%. That reduced to 4.2% in 2011 and further reduced in the recent years. This is the study for the children. And in the adult, the highest prevalence was seen in 1984. That was 27.2% of selective population. But in the general population, it reduced to 6.5% in 2011. And in general population, the prevalence was about to 9% and reduced to 5% in 2015 and further reduced in recent years. In high-risk population, Hep B is in injectable drug users prevail about 12%, and in the family members of the hepatitis B carrying person, it is about 20%. It is very high in professional blood donor, 18 to 29% in the professional blood donor. And in hemodialysis patient, it's about 14% in our country. The latest study done by our society in 2018 in the nationwide study, that the prevalence of Hep B was 5.1%. So total population infected with Hep B in recent years is about 8.5 million. The study done in the suburban area beside Dhaka city, the under 5 children infected with Hep B is 3.2%. In the overall prevalence, about 7 million males are infected with hepatitis B in our country, and 2.8 million female are infected with hepatitis B in our country, and 1.5 million of under 18 are infected with Hep B in our country. The major focus should be given to the child and the childbearing age lady of our country. That is about 18 to 45 years lady. They are of 1.8 million in our country, and 0.1 million childbearing age ladies are the source of HBV infection at current study. For Hep C in our country, Hep C accounts for 30% cases of cirrhosis and 70% cases of hepatocellular carcinoma in our country. In the published literature, demonstrate that prevalence ranges between 0.2 to 1% in general population of our country. HCV prevalence is 0.8% among the truck drivers in our country. Overall, males are predominantly affected by hepatitis C virus. highest prevalence are found in hemodialysis patient, and there is significantly high prevalence persisting in the people who had the emergency surgery. In our study in 2018, we could find that Hep C prevalence is 0.2%. That suggests that 1 in every 500 people are of HCV infected in our country. So, for further intervention, we will have to work on prevention, testing, linked to care, treatment, and chronic care. So, in conclusion, we can say that Bangladesh is on the high way of eliminating hepatitis B and Hep C. Hepatitis B is sharply reduced with successful EPI intervention. Further intervention needed. Special attention should be given to the special population, those at child and child caring age lady. Hep C is as before, but hopefully will be reduced by June. The special population should be addressed urgently by detection, access to care, and chronic care are the mainstay to eliminate the Hep B and Hep C in future. Hopefully, we will see the success story of our country by eliminating hepatitis B by 2030, Hep B and Hep C. Thank you all.
Thank you very much, Professor Alam, and some really important messages that you finished on there. I would now like to invite Professor Farooq Ahmed to speak on viral hepatitis control strategy in Bangladesh.
Good afternoon, respected participants and the dignitaries, especially the leader of viral hepatitis elimination campaigning in Bangladesh, Prof. Muhammad Ali. I am expressing my gratitude to the concerned people for allowing me to include this noble gesture for elimination of viral hepatitis in Bangladesh. And I am supposed to talk on what can be done in Bangladesh to eliminate viral hepatitis. And before telling this, I want to tell what is already done for elimination of viral hepatitis in Bangladesh. And for prevention or elimination of viral hepatitis, definitely the first step is to build up the awareness by educating the people about these viruses, the nature of these viruses, behavior of these viruses, how they are transmitted, how they could be prevented. So this is the first step to prevent or eliminate viral hepatitis in the society. And in doing this, I hope that we have definitely visible improvement in this field. If we consider just a couple of years back, I think only few people of our country knows about this virus. But right now, I hope most of the people of this country knows about this virus. And there is the preliminary success for this nation. And this has been successfully done by policymakers, physicians, and these noble people like Muhammad Ali and other senior teachers who are sitting in front of me. And also the different media and social media also included in this report to build up this awareness among the people. And we have impressive improvement in this field. And next one is about the method, ways of preventing this infection from one to another person. And definitely the universal preventive measures are very important. And I hope by this time we have also got impressive improvement in this field. By this time, most of the people of our country knows how to prevent these infections. And from the policymakers level, we already have introduced few things that has been very successful in playing a role to eliminate this infection, of which I should mention about the introduction of disposable syringe and blades, and also very standard screening of blood and blood products in different times, particularly during the time of dengue or some other illnesses like this, while we need a lot of blood and blood products for our people. So these are the areas which already we have improvement, but I hope in these areas we need further improvement also. So we have to ensure these disposable syringe, blade, and all other related things to everybody. And we have to ensure safe blood or blood products product transfusion to everybody in all the centers in the country. So these are the areas where we need some, I hope we need some improvement. And then about vaccination, definitely regarding vaccination, we have got exemplary improvement, and for which our Prime Minister received, I think in 2019, she received vaccine hero award from Gavi because of her impressive improvement of vaccination. And the vaccination coverage successfully covered about 90% of our popular newborn children. That is really, really impressive. And we are really grateful to our Prime Minister that she included this Hepatitis B vaccine in EPA schedule back in, I hope, in 2006. So introduction of this vaccine to EPA schedule, of course, free of cost to all the children of our country is a great success for a nation like us. And we just need to start this vaccine not only at 1.5 months of age, but we have to try to give this vaccine at birth. So by giving this vaccine at birth, instead of at 1.5 months that we are now practicing, will be another areas where we do have some scope to work. And if we can do this, if we can ensure the vaccine to our newborn baby at birth, that will play a big role in overall prevention of hepatitis B virus infection in our country. And by doing this, introduction of this vaccine at birth in different countries, particularly Taiwan, they achieved a remarkable improvement in this field. So we have to work in this field. And vaccination in adult, by this time, our government has started to vaccinate adult in few centers of our country free of cost. And in my center where I'm working now, we are providing this vaccine to adult free of cost. So this is another noble gesture from our government to ensure this vaccine free of cost even to the adult. And we have to include also the people of high risk behavior, high risk for transmitting these viruses in our country. And I hope in near future it will be in reality that we will have universal coverage even for the adult or even for these high risk people. And that is the field which we need some improvement definitely. And last of all, if we can successfully treat the cases, that is another area that may help in preventing this or controlling this infection. And we are very fortunate that we are getting this effective drug that are now available all over the world. We are getting this drug at very affordable prices. That is a great gift for us from all community and also from our government. That people are getting this drug at very affordable prices. And fortunately, recently government has also giving this drug free of cost to these people. And in my centers, we are now giving drugs, all these drugs free of cost. So maybe in the future we'll be very fortunate to get these drugs in all over the country free of cost. That would be another giant step in the control of hepatitis infection in our country. And with these few words, I want to tell you once again that government has done a lot of impressive improvement in the field of viral hepatitis, in the field of control and prevention of viral hepatitis in our country. And we people as physicians or opinion leaders, we have some role to play to improve it further and to improve it to an extent that will be really absolutely helpful to eliminate viral hepatitis by 2030. With these few words, I want to thanks one again to the organization.
Thank you very much, Professor Ahmed, and for giving us that overview and highlighting where some of the gaps still are. And now I would like to invite Dr. Gholam Azam to really give us a focus on prevention of mother-to-child transmission of hepatitis B in Bangladesh.
Very good afternoon, honorable participants and the representatives of the international collaborating agencies. I am Dr. Gholam Azam, going to talk on my assigned topic, prevention of mother-to-child transmission of hepatitis B virus. We know from our previous speakers already said that World Health Assembly endorsed the Global Health Sector Strategy on viral hepatitis, which calls for the elimination of hepatitis B virus and other viruses also to reduce by 2030 to attain a sustainable development goal. And there is a set criteria that 90% reduction in the new cases and 60% reduction in the mortality rate. So elimination of hepatitis B virus as a public health threat requires a reduction in the prevalence of hepatitis B surface antigen to below 0.1% among children of 5 years age. And these can be achieved through universal immunization of newborns against hepatitis B and other interventions to prevent mother-to-child transmission. Let's recall one publication that we carried out since long in 1998, published in the American Journal of Tropical Medicine and Hygiene, keeping in mind this objective actually. And the title of our work was Detection of Hepatitis B Surface Antigen in Pregnant Women Attending a Public Hospital for Delivery, Implication for Vaccination Strategy in Bangladesh. And this work was done before the implementation of universal immunization strategy in Bangladesh. So the objective was to determine the priority of hepatitis B immunization, considering the expenses of the universal immunization compared with the immunization cost of risk babies born to HIV positive mothers. And that was a large study that included 1,800 parturients attending a public hospital for delivery. And we found 3.5% mothers were HIV positive. And interestingly, 65% of the mothers were asymptomatic, and without having any risk factors, without screening them, this could be missed, and that happens actually. And we concluded in that paper that the presence of HBsAg or HBe antigen is not required to give vaccine to the children. Rather, it should be given immediate after birth within 24 hours actually. So that was our recommendation, and we proposed for universal immunization to include in the EPA schedule in that paper. And that is not the end. In the last year, Professor Muhammad Ali, sir, with his National Liver Foundation of Bangladesh, in collaboration with our local societies like Hepatology Society, Dhaka, Bangladesh, Bangladesh Gastroenterology Society, Association for the Study of the Liver, Dhaka, Bangladesh, Obstetrical and Gynecological Society of Bangladesh, OCSB, UNFPA, BRAC, Mary Stopes, organized a talk on this similar topic, how to prevent mother-to-child transmission. So it's going on. Actually, we are aware of this burning issue, and we like to stop this transmission because vertical transmission is a risk for the South Asian region. And finally, may I now express some recommendations that endorsed by WHO. In the latest guideline by 2020, they advised or they advocated to all infants should receive their first dose hepatitis B vaccine as soon as possible after birth, preferably within 24 hours. The dose should be followed by 2 or 3 more doses in the primary series, and all pregnant women should be tested for hepatitis B as well as HIV and syphilis. WHO recommends that pregnant women tested positive for HBsAg should be further tested for HBV DNA and or HBe antigen or HBV DNA costing are not visible. And if the person or mother is only HBsAg positive, having no marker of infectivity, that is DNA or E antigen is low, then the mother need not to get prophylaxis by COVID. But the baby should be, the children should be vaccinated as per schedule. But when the mother is surface antigen positive as well as DNA or antigen positive, then the mother should start in the drug prophylaxis by tenofovir earliest by 28 weeks of pregnancy or as soon as possible when it's possible before delivery of our baby to reduce the viral load. And to continue it depending on the mother's physical condition, whether if it is a cirrhosis case, early cirrhosis, then that should continue. So this is the recommendation. And they also recommended that when HBV DNA is a molecular test, sometimes it needs the laboratory facility and costing. If not possible, then e-antigen can be done. And finally, I have some issues to raise here in this August gathering about which are not touched here. That is, whether we should screen with only surface antigen or we should go for HBC4 antibody, because it will find more infected mother. And another issue, whether we can also give, we are now giving tenofovir disoproxil fumarate, but whether tenofovir alafenamide can be given because its dose is low, 25 milligram, and it is more safer. So this is my further direction if we could make some clinical studies on this stuff. So thank you very much. And I am fortunate to get the chance to speak here. Thank you very much.
Thank you, Dr. Azam, for all your recommendations and the ways in which we can prevent mother-to-child transmission of hepatitis B. I would like to call Dr. Farouk Ahmed up next, Head of Department of Hepatology at Dakar Medical College and Hospital. He'll be speaking on testing and vaccines for hepatitis B and C.
Assalamu alaikum. I'd like to express my deep gratitude to Professor Mohammed, founder of Liver Foundation of Bangladesh, for inviting me in this Global Health Congress meeting. Distinguished speakers from home and abroad, and learned audience, I would like to give a short emphasis on testing and vaccination specifically for hepatitis B and C viruses. All of you know that Hep B and C are hepatitis viruses that cause chronic infections in liver and cause chronic liver disease, liver cirrhosis, and some of the grave complications like hepatocellular carcinoma or liver cancer. So hepatitis B and C usually transmits through sexual, genital, and parental route. Bangladesh is an intermediate prevalence country for HPV and low prevalence for HCV infections. Now the testing for hepatitis B. We all know that hepatitis B surface antigen or HBsAg, which is the most commonly used test for diagnosing acute and chronic infection. So HBsAg is the earliest indicator for HBV infection, and it usually appears months after the exposure. And it indicates the person is infectious, acute or chronic. The next one is anti-HBC total. It develops in all HBV infections, usually indicates HBV infection in the past. Only occurs after HBV infection, and it never develops with HBV vaccination. It generally persists for life. Now, IgM anti-HBC. It appears in acute disease at the time of illness, indicates recent infections with HBV, and it appears 4 to 10 weeks after appearance of HBsAg. It is the best serologic marker of acute HBV infections. As far as HBe antigen, it indicates high level of infectivity, appears 1 week after HBsAg and persists for variable periods. Now, anti-HBs, that is antibody to hepatitis B surface antigen. The presence of anti-HBs following acute HBV infection generally indicates recovery and immunity from reinfections. It appears several weeks or months after disappearance of hepatitis B surface antigen. It is the marker of immunity after HBV vaccination policy. Now, regarding hepatitis B elimination, what is the objective? We know that HBsAg, once positive, it usually remains positive. But the objectives of treatment for Hep B infection is to prevent chronic liver disease,
and prevent liver cancer, and also to prevent acute symptomatic HBV infections. Now, the strategy is to eliminate hepatitis B transmissions or prevent perinatal HBV transmission, routine vaccination of all infants, vaccination of all children, and vaccination of high-risk adults. According to the Advisory Committee on Immunization Practices of CDC USA, they have recommended to whom we should give hepatitis B vaccination. This includes all infants, all children under 18 years, persons at occupational risk, like clients and staffs of institutions for developmental disability, hemodialysis and immune-compromised patients, blood product recipients, persons with diabetes, persons with chronic liver disease due to other reasons, households of sexual contacts of HPV carriers, injecting drug users, and incarcerated persons. They all are recommended for hepatitis B vaccination. Now, in short, hepatitis C virus, we know that the transmission occurs by illegal injecting drug use, transfusion or transplant from infected donors, chronic hemodialysis, injuries with contaminated needles or sharp objects, birth to infected mothers, and sexual contacts. Now, HCV testing that's routinely recommended for healthcare workers, emergency workers, public safety workers, after needle or stick mucosal exposure to HCV positive blood, children born to HCV positive mothers. Test for HCV infection. In short, I'm telling that anti-HCV is the usually first test we have to do. It indicates past or present infections. It is done by enzyme immunoassay, EIA, or enhanced chemiluminescence immunoassay. In other words, HCV RNA. It is a quantitative test. It determines the concentration of HCV RNA, useful in assessing response to antiviral therapy. Now, HCV genotypes. You know that there are 6 genotypes and more than 90 subtypes. And among these, 1, 2, 3, 4, 5, 6, genotype 3 is more common in Bangladesh. And useful for persons with chronic infections who are being considered for antiviral therapy. And it also indicates response to antiviral. We can see the response to antiviral varies to different genotypes. And we know that genotype 1 is usually less responsive to therapy. Regarding hepatitis B and C vaccine, we know that no vaccine is yet available for hepatitis C. Regarding Hep B vaccine, it is recommended DNA techniques. It is manufactured by this technique, and it is already incorporated in our EPI schedule for about last 2 decades. And we are already getting the benefits from these vaccinations from our EPI schedule. And Hep B vaccine, Hep B immunoglobulins, and combinations are considered as preventive measure for babies born to infected mothers. It is safe during pregnancy and breastfeeding. Regarding Hep B vaccine effectivity, we should do anti-HBs after 3 doses of Hep B vaccine, 1 to 4 months later. And if the level is in between 10 and 100, then we should give a single booster dose. And if it's more than 100, then we can say that person is immune to Hep B vaccine. So with these words, I'd like to thanks to all audience. Thanks.
Thank you, Dr. Ahmed, for taking us through the importance of the HBV vaccine and the HCV vaccine for all ages. We'd like to call Professor Safwat, Professor in the Department of Gastroenterology at Jalalabad Medical School, Bangladesh. She'll be talking on blood transfusion and surgical safety.
Good afternoon. I first thank today's organizer for inviting me to join today's session and giving me the chance to speak a few words in front of this learned audience. What can be done to eliminate hepatitis in Bangladesh? Yes, today's thing is the burning issue in the health sector of Bangladesh. And my part of discussion is blood transfusion and surgical safety in Bangladesh. To ensure safe blood transfusion in Bangladesh, we have National Safe Blood Transfusion Program under Ministry of Health and Family Welfare. We also have Safe Blood Act to ensure the right of our people to get safe blood by transfusion is needed. And it is noted that the transfusion-transmitted infection reduced through the introduction of mandatory blood screening backed by the Safe Blood Act. But still, we have a long way to go. With the rapid expansion of healthcare facilities, the need for blood transfusion is rapidly growing. And the estimated demand of blood transfusion is around 800,000 units per year in Bangladesh. We have three types of blood donors. Some are voluntary blood donors, some are friends and relatives, and some are professional blood donors. And we are deeply concerned with these professional blood donors because all blood-borne diseases rate of these blood-borne diseases are very high in professional blood donors. So we must encourage our healthy people to come forward for voluntary blood donation. And all private and public blood centers are supposed to do the 5 screening tests: the HBsAg, the anti-HCV, the test for HIV, for malaria, and VRL. And they are doing this, but we have lacking in monitoring. We have lacking in quality control. So we have to come forward to work for strictly monitor this screening process and the quality control under National Safe Blood Transfusion Program under Ministry of Health and Family Welfare. There is lack of manpower in the blood transfusion units. So we have to work to create skilled manpower in blood transfusion units. And now to speak a few words about the screening test that we are doing. In most of the centers, the screening test is done with the rapid strip test. So rapid strip test may be false negative in some of the cases where the person might have some hepatitis B virus infection. So we might miss those patients if we are doing with rapid strip test only. All centers doesn't have the ELISA method. Moreover, we are doing HBsAg test only to detect hepatitis B virus infection before blood transfusion. But if the patient is incubation period, if the patient is window period, or if there is occult hepatitis B virus infection, or if there is mutated virus, we'll miss the diagnosis. So it will be much better if we can include anti-HBs total and anti-HBs in the screening process. Now, about the safety of surgical safety. In our country, the surgeons and their team are more exposed and more vulnerable to be exposed in hepatitis B and C virus infection. So surgeons and they're using gloves, but merely using the gloves is not protecting them from needle stick injury or protecting them from injury from sharp instruments. So all surgeons and their team should be vaccinated, and it is better if we can offer them free vaccination from the government. On the other words, about pre-operative screening. In many of the hospitals, pre-operative screening is not well maintained, especially the primary and secondary level hospitals. If you can go for pre-operative screening, we can reduce patient to patient and patient to surgeon teams spread of infection. Every hospital should have a committee for rigorous infection control program so that their staff will adhere to the principles of universal precaution, like safe injection, hand washing, wearing gloves, and wearing barriers. Another space where we need to work a lot is biomedical waste management. Biomedical waste management, and we should take necessary steps in disposal of body tissue, sharp instruments, needles, and etc. Another thing I need to mention over here that in our country, we have a culture of body piercing, like piercing of ear lobule in case of female, or piercing the nose in case of female. And in most of the cases, this body piercing is done by non-medical person. They have no idea about hepatitis B
no idea about hepatitis C. So it should be mandatory that these body piercing should be done by medical professional in a hospital setting. And at last, but not the least, I should emphasize on awareness of healthcare workers to maintain the universal precautions. Repeated motivational session is mandatory to increase the awareness of healthcare workers. Thank you so much. Thank you.
Thank you so much, Professor Safwa. I think, blood transfusion and surgical safety is definitely something I think, at least on the global stage, we maybe don't talk about enough, but is really an incredibly important part of hepatitis prevention. And so now I would like to invite Professor M. Anisuraman to join us on the stage to speak about injection safety and harm reduction.
Good afternoon, all the guests from home and abroad who joined from Geneva and London, and also our distinguished professors from different parts of the country has also joined this meeting, and some of the guests also come here to join this special meeting. So good afternoon, everybody. So injection safety and harm reduction. All of us know that hepatitis B and C are usually transmitted by infected needles and syringes and unsafe blood transfusion. So these things always we have to keep in mind. So always the parenteral drugs and infusions should be administered by safe technique by the trained person. Our government has already passed a law that there should be no use of disposable sterile medical devices in healthcare facilities. But there is some pitfalls because these are not supervised, so there can be reuse of the things. Sharing of needles is a problem for the drug abusers, which is to be combated through the multidisciplinary approach. Because it is very alarming that those who are IV drug users, the incidences of hepatitis B and C virus among them are very high. In a study some years back in our country, the seroprevalence of hepatitis B virus, surface antigen, anti-HBC, and anti-HBs and anti-HCV antibodies among IV drug users were found to be 6.2%, 31.8%, 11.6%, and 24.8% respectively. That means about 50% of them have exposed to hepatitis B, and about 25% of them have developed hepatitis C. So this was published in a journal in Population and Nutrition in December 2000. So for the safe injection practice, nurses, paramedics should be trained for safe injection and sterile needles. Before using any injection, hands should be adequately cleaned. Among the dialysis patients, the incidence of hepatitis B and C virus are very high. We have already heard from some of our speakers. And the role of safe blood transfusions, the use of dialysis catheters, and the role of nurses for introducing for accessing the vascular access by them is very important, because they usually work very crowded situation. Sometimes they don't clean their hand properly. Sometimes they introduce needles to one patient and they pose for another patient without proper hygiene to their or cleaning their hand and properly. So there is a lack of and there is a gap. So there can be transmission from one patient to another. Because we have studies that Bishop Watt is there. He had the study in the dialysis patients, how they are being transmitted hepatitis B and C. So, why the hepatitis B and C virus transmission is so high in dialysis patients. So another thing is already mentioned on the speaker about the speaking, tattooing, and sometimes it's not our practice, the Chinese practice, that means this acupuncture. These needles are sometimes become unsterile, and these are very, very much infective and can be, these people have no hygienic idea, so they can transmit the virus easily to other people. And in rural Bangladesh, a very vast number of so-called village doctors. So we have to address also them. We have to educate also them, because they are the primary care physicians, because all the physicians cannot reach the very remote areas of the country. So many of the times, they are the primary physicians taking the role of primary physician in the rural distance remote areas. So we have to train them about the safe use of needles and syringes. And another very interesting things in Bangladesh that happens. There are some gypsy migrant population, called in Bengali the Pede. They sometimes they are snake charmers, or they play with the monkeys and attract the people. And sometimes they take part as a traditional healers. So sometimes they give treatment, like if somebody has pain, they attract by these things and they attract especially the ladies. If they have some pain, they'll say, we will give you some treatment and you will be cured. So what they do, they by needle prick, they in the pain area, they let the blood, and they by some special measure, they suck the blood from there, and they are telling that we are sucking the impure blood from your body and you will be cured from the pain. So these are facts happening, but we have to address all these things, because it is also very important for the transmission of this type of hepatitis B and C virus in rural population in our country. Because it has all are going traditionally, and we have to break this chain. Otherwise, the primary goal to eliminate the hepatitis B virus in 2030 will not be achieved if all these things are not addressed properly in the future. So thank you again, all the organizers and our distinguished guests who came here for this August gathering. So thank you again.
Thank you, Professor Rahman, for speaking on taboo topics that aren't usually spoken about, and ways in which those practices spread hepatitis. I'd like to call Professor Saeed, former head of the Department of Medicine in Chittagong Medical College and Vice President Hepatitis Society Bangladesh. He'll be speaking on the treatment of hepatitis B.
Good afternoon, respected participants from home and abroad. First of all, I'd like to express my heartiest thanks and gratitude to the organizer, especially Professor Morgan Stark, for asking me here. All of us are very much eager, including WHO, to eliminate hepatitis, viral hepatitis by 2030. Keeping in mind, regarding in the perspective of treatment of hepatitis B, to speak, hepatitis B patient, they come in two setups. One is acute setup, another is chronic. For acute, especially if people do not know about their hepatitis B presence, they come with jaundice and illness. When we do investigation, they are found to be positive. They were never aware of hepatitis B, being himself or the whole family. This is the reason for, so awareness is most important for the whole community, number one. And regarding the treatment of acute hepatitis B, nothing specific is needed, only supportive treatment will help. We are more interested for chronic one. Chronic one, usually how do they come to us? Usually, vast majority of the chronic hepatitis B, they come with the paper having positivity. What is the issue? Why you have come here? When I asked the patient, just look into the paper, there is a positivity that was detected in screening, either going abroad or blood donation or somewhere screening test. Or doctor asked to do the examination, to test, to be screened for the whole family. Anyway, when they come, we ask for some investigation to distinguish them whether they are active or inactive carrier. A panel of investigation, either apart from clinical, that is biochemical, serological, virological, and even the elastography or biopsy, that takes handsome money. Sometimes, just I like to highlight the challenges of dealing with this patient. The cost, sometimes a group of patients, a section of patients cannot afford. After that, when I start prescription, give prescription, yes, there are two groups of medicine. Prior to 2012, there was injection, another group was antiviral, they would be ready to use drugs. But at that time, neither the injection nor the oral drugs were very much effective. In the perspective of injection, especially the regular or regulated one, the patients were reluctant to take this injection because of side effects, because of cost, because of possible feasibility. Everything was they used to do not accept it. Anyway, after 2012, the pioneer very excellent drugs which are available in our country is lower cost in comparison to Western country, Antiviral and Canopy group. When we prescribe the drugs, usually the those who are active, they accept it, they take it. One of the problems here, the follow-up of the patient, almost 50% patient follow-up is not appropriate. They do not attend. They do not like to do the regular investigation after 3-4 times. After they become a bit annoyed. Why you are asking so many investigations all the time? Whenever I come to do all the investigation, treatment is drug is saying. Anyway, these are the actually challenges. These are the actual problems of dealing with this group of patients. Thirdly, after 1 or 2 years finishing the treatment, when we go for DNA investigation, DNA examination, DNA negative, then the source will be asked, should I stop the medicine? How long I will take it? When we say that no, you have to continue this one because we know the treatment of hepatitis B is the till date, the consensus is lifelong. But they are not, a group of patients that are not interested to continue that one. Sometimes they stop it, ignore it. And even they forget to visit the doctors. After 2, 3, 4, 5 years later, they sometimes come. When I ask them, why you have come now? Oh, this morning I started feeling pain abdomen. That's why anything wrong with liver. That's why I come. Are you taking the medicine? No, because he sometimes says very interestingly, you know that I'm okay. The DNA has become normal, negative. So that's why I was found fit. This is the common happening in the in our country. Here, one thing is very much mentionable there. Asking the investigation and continuing the treatment, and that is screening all the family members and contacts. It takes huge amount of money. It is a reality. When they tell it, it is a reality. So, question comes: if there would be some support, or if it would be some free of cost, it would be easier for adherence, for tracing them, for continuing the treatment, for curing them. And so that is also an important part of prevention. Other group of patients, they come usually with complication or advanced cases like cirrhosis, already ACC. This group of patients, actually, when they come, vast majority of the patients, they are in advanced stage. Anyway, those who are cirrhosis, they have to continue the treatment. Again, the treatment, the problem we face that the bundle of that is your medication they have to take, or when they become sedated, they cannot bear the stress. That is one hindrance. And those were developed already ACC due to hepatitis B. The life expectancy is also minimum. That's why sometimes they quit the medication, they stop the medication, they do not take the continue that one. That is another problem for elimination. There are some other special situation. There are some other special situation that there is pregnant mothers, treatment of pregnant mothers where SBS is a positivity. Already we know when the count is more than 10 to the power 6 viral count, we prescribe tenofovir, and that has to be continued. And they're good, actually they come because they have a baby and they are very nice. They are happy that the treatment is successfully going on. Transplant patient, in our country, we have not come across only 3 or 4 patients from transplant, liver transplant. They are taking these hepatitis B, anti-hepatitis B drugs. Regarding the resistance, actually, very truly speaking, we have not encountered this problem. Actually, we saw the patient of failure because of they did not take the medicine properly, regularly, and timely. That's why there was treatment failure. But about the resistance, we are not, our knowledge is very poor, low. Anyway, with these few words, I'd like to conclude with saying that awareness of hepatitis B transmission, their treatment, and the good effect of treatment is very important, which is very, very low in our country. And the awareness program is actually, what I feel, is limited to the city. It should be ventilated to all the people, including up to the village and remote area. Another thing is, second thing is financial support. Financial support by the government, by WHO, by philanthropists, NGO, and others. That should be looked for. This year, I like to conclude here. Good evening.
Thank you very much, Professor Saeed. And I think that really does touch on two of the key barriers there, awareness and financing. So now we'd like to invite Professor Salima Rahman to speak around treatment for hepatitis C.
Good afternoon, everybody. First, I'd like to thank and congratulate Professor Muhammad Ali for inviting me and arranging such a nice gathering, which has international collaboration. And the topic, today's topic is what can be done to eliminate hepatitis from Bangladesh. And my job is to say on how we can help to eliminate hepatitis C in Bangladesh. We all know, we have already seen from, have learned from other previous speakers that Bangladesh is a low prevalence area of hepatitis C. And the prevalence in this country is approximately 1%, some study a little less than 1%. So prevalence is not that much. But we are a very hugely populated country. And all of you know that in contrast to the hepatitis B, most of the patients positive to hepatitis C needs treatment because 85 to 95% goes to chronicity and most of them are RNA positive. So number in comparison to hepatitis B, I have calculated is not much less than hepatitis B because most of the hepatitis B do not need active treatment and they need follow-up. But in hepatitis C, most of them is treatment. In even acute hepatitis C, if we can recognize, it also needs treatment. The main problem, main obstacles in the elimination of hepatitis C is that it usually very rarely causes symptoms because it do not usually cause jaundice. It remains silent and not even silent. It remains silent for many years. So we cannot know that who is bearing the hepatitis C. So treatment, before treatment, we must diagnose hepatitis C and there should be facilities. There should be cheaper facilities for diagnosis of hepatitis C and to do ACV RNA that to recognize who are the active disease. And next to that, if we diagnose, we need to treat the patients. And again, the main problem, though generic products are cheaper than Western countries, but still, as we are a poor country, it is still a very high price for our people. So these drugs should be available to the consumers in a comfortable way. How can you give them in a comfortable way? Government should come forward. We have seen government has come forward. Director of the Sheikh Russell Hospital has said they are giving free of cost these drugs. IPG, BSMB is also giving free drugs, and Solimullah Medical College, we know that they are also giving free of drug, but we should extend these facilities up to district level so that we can eliminate hepatitis C from Bangladesh, because the treatment success is very nice and direct acting antivirals are very effective and they are more effective. They are more than 95% effective in most of the cases. Another problem in eliminating in my country is that some of the patients, though they are not very resistant, a very small amount of patients here occur, and we should have the drugs which are very costly in the Western world also, and also be available because in some of the cases we face problem in treating those cases. Another thing is that there should be development of awareness about hepatitis B and C both. because people used to think previously that if you get hepatitis C, you will not survive. But this should be communicated to the people that hepatitis C is almost a curable disease. It is diagnosed before the development of cirrhosis. So this is treatment is better than hepatitis B, much better than hepatitis C, because it is a curable drug. And the scientists are claiming, they are hoping that they will eliminate hepatitis from this planet in near future, like the other communicable diseases. So we must aware the people through radio and television, through newspapers, through billboards, through seminar and symposium like this. And also we should aware the people through social leaders, through political leaders, and through imams of the mosque, like these people were very with the teachers, because they are very close to the common people. So these are the ways we can help. Another important thing that we should interrupt at the point where there is transmission of hepatitis C. What are the interruption points? In dental treatment, in endoscopy treatment, in surgical treatment, in blood transfusion, where we should very nicely screen the blood before transfusing this blood to the human being. And some of our speakers have said there is a regulation from the government that we should not reuse the disposable syringe and needles. So we should strictly follow this. So if you follow these things, we can eliminate hepatitis C from Bangladesh. And another very important thing I have marked in our study, we have also seen that nose and ear pricking by common needles and circumcision by the hajams. And these two we have seen in our study is one of the source of transmission of hepatitis. So this should be done in a hygienic way and in a sterile instrument and needles. With these few words, and thanks to the organizer for inviting me and giving me the chance to talk on hepatitis B. Thank you all for your questions here.
Thank you, Professor Rahman. You definitely talked on some important barriers such as financing and awareness also, and also the need, the fact that hepatitis C can lay dormant for a while and not be detected, have symptoms, and people often ignore those signs. So that's touching the point to the need for testing. I'd like to call Major General Hussein next to talk about the stigma, discrimination, myths and conceptions, and the role of media.
Good afternoon, everybody. My special thanks to Professor Mohammed Ali for allowing me to participate in this very special meeting on the subject of global health contest meeting. And the main theme is what can be done to eliminate viral hepatitis in Bangladesh. Hello to participants across the globe, particularly Jessica Hicks, who seemed to be very serious this morning over there. So good morning to Daniel, Joseph, Tucker, Cynthia, and Kukua Ini Okiri. I must say that you are far away, but you have missed a very good lunch this afternoon. The problem is that I have been sharing with Professor Salimur Rahman and Professor Farouk is that we are attending a meeting in Dhaka, Bangladesh, but the pacemaker is in the United Kingdom. Nevertheless, my subject is stigmatization, discrimination, myth, and misinformation relating to hepatitis B and C, and the role of media. I'll try to be brief, but I'll maybe take 1 minute more from Professor Mohammed. Stigmatization refers to the action of placing a derogatory remark or disgrace upon a person based upon some acquired or other illnesses. Stigmas commonly relate to social gender, race, intelligence, or health attributes. Several illnesses are stigmatized, particularly mental illnesses has been stigmatized for a very long time in our society and many other societies. AIDS, sexually transmitted diseases, drug addiction, and hepatitis. The stigma is associated with lack of knowledge surrounding viral hepatitis transmission. Stigma involves negative presumptions about hepatitis B virus, hepatitis C virus, relating to substance misuse, sexual promiscuity, homosexuality, and sexuality. What is this impact of these stigma? Self-stigmatization, internalizing the society's negative perception of the disease. This leads to shame and fear and isolation. This leads to frustration, depression, and reduced quality of life. Many are deprived of even healthcare facilities. Many have lost their job because of discrimination against the carriers of hepatitis B and C. I have personally witnessed discrimination against hepatitis B and C in the form of job denial and job loss. I don't like to go into the details and the circumstances in which these persons were deprived of their rightful job. Rejection at job entry has been commonplace in this country and in many others too. This applies to job, particularly when they apply for a job abroad. Bangladesh has almost over 1 crore people serving Middle East and other countries. So there were restrictions on people having hepatitis B and C positivity. There are a lot of myths which surround hepatitis B and C. People have been saying that if you have hepatitis B and C, you have a rotten liver and you're going to die soon and you have a 100% chance of developing liver cancer. So your future is doomed. So these are some of the myths, that surround these two illnesses. All hepatitis are considered to be extremely contagious illness. That means nobody would like to go even, meters close to the individual who is suffering from hepatitis B and C. They suffer isolation from peers in workplace, in academic institutions. And there are instances of social isolation too. Role of media. The media has an immense role in mitigating these wrong perceptions prevailing in our society. I think there's no shortcut, They are part of our culture, negative culture. If anybody has these illnesses, it spreads like wildfire. And these people, are not denied of the rightful interactions in the society. Media, which includes print and electronic, and also these days, social media has a tremendous role in kind of spreading the positive aspects and health awareness in these two diseases, hepatitis B and C. So I think they're doing it, but the health workers and health leaders have a bigger role in mitigating these concerns, particularly these. Stigmatization. Social is that we have been harboring about 1 million displaced Rohingya population in the southern part of our country. In spite of our very limited resources, Government of the People's Republic of Bangladesh has been taking care of this displaced population for the last 5 years, 4 years or so. So this is a great drain on our finance. However, Western countries, donors have been helping a lot in keeping them alive. They are a confined population. 1 million population confined in 2 small or 3 small camps in Kutupalong, in Noyapara, and recently in another place. So they are confined, and as you know, when people are confined in small places, the transmission of disease, the rate of transmission of disease, particularly this communicable diseases, are very, very high. And that is what has happened. Our study, led by Professor Muhammad Ali, has found out this fact that 11% in the general population of the Rohingyas, and near about 8% of the pregnant population in Rohingya, they are suffering from hepatitis C. In Bangladesh, the general prevalence of hepatitis C is less than 1%. So this is a kind of a bombshell, no? So I have calculated, there was about 50,000 pregnant women at the time of study. And of them, with this prevalence rate, 4,000 pregnant mothers were positive for hepatitis C. And the general population, the prevalence should be around 100,000 positive hepatitis C in this group of people. This is extremely alarming. And I think international collaboration is needed, government intervention is needed, and the Liver Foundation of Bangladesh and other agencies was working to improve this health condition. We want to see this collaboration, and without this collaboration, it is extremely difficult to eliminate viral hepatitis in this camp first, and then we can go to others. So I'd like to thank Professor Muhammad Ali once again and all the audience. Thank you very much.
Thank you so much, General Hussain. We touched on some very important points. The myths and misconceptions are what is leading to discrimination and stigma amongst people who have hepatitis. So we should work towards cutting those myths and misconceptions out and using social media as a way to promote and encourage people to get testing and show people that hepatitis is not a death sentence. I'd like to call Tasneo Noor to the stage, the president of Bangladesh Medical Student Society, who will speak on the role of the medical students.
Hello, good evening, everyone. First of all, I'd like to thank National Liver Foundation, World Hepatitis Alliance, and all the representatives of all the other participating organizations present here today for this wonderful opportunity. Before I begin, I'd like to give you a brief overview of the organization that I'm representing. I am currently the president of Bangladesh Medical Student Society, which is a non-political, non-profit voluntary organization of medical students of Bangladesh. We are the national member organization of IFMSA, the International Federation of Medical Students Association, which is one of the largest and oldest student organizations of the world, founded in 1951, just post-World War, which is maintaining official relationships with the WHO since 1961, and where we collaborate on several projects, including campaigns and internships, to advocate for matters that we believe in. IFMSA currently connects and engages 1.3 million medical students from 138 national member organizations in 123 countries around the globe. As the national member organization of IFMSA, we share its vision of bringing people together, mainly medical students, for advocating about pressing issues that matter, that help us to shape the future, and it does deliver. Our projects, our campaigns, and our activities positively impact the physicians-to-be and the communities they serve. We work through 6 standing committees: the Standing Committee of Public Health, SCAW, the Standing Committee of Sexual and Reproductive Health and Rights, including HIV and AIDS, SCORA, the Standing Committee of Human Rights and Peace, SCORP, the Standing Committee of Medical Education, SCOME, and Student Exchange Programs, Standing Committee of Professional Exchange, and Standing Committee of Research. So our work with hepatitis aligns with the Standing Committee of Public Health, which aims to bring together medical students from all over the world to learn, build skills, and connect in order to address issues that are related to public health, including global health issues, health policies, health promotional education, and activities. SCOP works in 4 focus areas, mainly mental health, communicable disease, non-communicable disease, health systems, environment, and health. So hepatitis falls under the communicable disease. And every year we celebrate the World Hepatitis Day 20th July by hosting various campaigns and activities in order to spread awareness about hepatitis. Last year was very special for us, 20th July, World Hepatitis Day 2021, where we collaborated with National Liver Foundation and World Hepatitis Alliance to host a campaign named Mission Hepatitis Free Future. This campaign was hosted during the pandemic, so it included both an offline and an online segment. The online segment included webinars and online poster competition and article presentation competition. These competitions involved 21 local committees from across the country. This aimed us to include medical students from all over the country, from all districts to participate in order to spread awareness nationwide. We also hosted 2 webinars. The first webinar was in the theme of hepatitis and weight, in accordance to the theme of Hepatitis Day 2021, where we had speakers from National Liver Foundation, where Professor Dr. Mohammed Ali joined us, and also World Hepatitis Alliance. The second webinar, we welcomed questions from the audience. And these were also answered by Professor Dr. Mohammed Ali in order to remove the stigma that are associated with hepatitis. The offline segment was also very interesting. With the help of National Liver Foundation, we hosted a hepatitis screening workshop, through which 20 medical students they learned how to screen for hepatitis in the National Liver Foundation office setting. So what we medical students can actually do is what we have learned throughout the year by collaborating with National Liver Foundation and World Hepatitis Alliance. We want to create the domino effect. We, a set of students, have learned in 2021, and we want to go to all our local committees present throughout the country, and we want to teach them what we have learned, and we want to reach the communities there and spread awareness the way we have learned this year. And we have the big workforce of 5,000 medical students from Bangladesh Medical Student Society. What we need is the logistical support from the organizations that are present here with us today. And what we want to do is engage you to create the change that we want to see, and we need your support for that. We have targeted specific communities such as underprivileged teenagers who are involved in drug abuse, which is also a triggering factor for hepatitis. We want to go to rural communities and promote awareness about maternal care and spread awareness about the transfusion between mother to child. We also want to emphasize on sex education within the youth for practicing of safe sex, which would also be a contributing factor to minimizing the spread of hepatitis. Thank you all. But lastly, I would like to say another thing. I have recently graduated and now practicing as an intern doctor. This was not part of my presentation, but I wanted to say this. When we work in the, when we are doing our job and we're assisting operations with our doctors, whenever we get a needle prick, they keep asking us, are you vaccinated for hepatitis B? And some of us say yes, but most of us actually say no. And this is a huge problem. So when we're talking about risk groups, we're talking about mother-to-child transmission, about underprivileged communities, but we're forgetting that health workforce is also a huge at-risk population. So I would like to take this opportunity to talk about the importance of introducing vaccination for medical students when they're getting admission to medical schools. If we try to make this a routine where as soon as a medical student is getting admission, they're also getting vaccinated hepatitis B, I think we'll have a huge milestone and we'll be able to reduce the transmission within the health workforce, because medical students are the future health workforce, right? So thank you very much, and thank you for this opportunity.
Thank you, Tasneer. It's lovely to see you again. And I think that your last message there around vaccination for healthcare workers is incredibly important. And I do hope that we see that happen at some point in the future. Unfortunately, our next speaker, Arifin Rahman Himal from the Youth Club of Bangladesh, was not able to join us, but we are incredibly fortunate to have Dr. Afsana Alamgir Khan with us from the Director General of Health Services in the Ministry of Health and Family Welfare. She's the Assistant Director of the Communicable Disease Control, and she's very kindly agreed to speak today. So thank you very much again, Dr. Khan, for joining us, and we appreciate you taking the time to speak as well.
Assalamu alaikum, good evening, and good afternoon in Geneva and London. Thank you so very much, Professor Mohammad sir, for inviting DGHS, Ministry of Health and Family Welfare, especially Communicable Disease Control. So on behalf of our Director Disease Control and Line Director Communicable Disease Control, Professor Dr. Najmul Islam, I am on behalf of him representing DGHS. Before I start to say something about what the national program is doing, what the Ministry of Health and Family Planning is doing, I would like to show my respect, because to whom? To the, as you know, in 1971, we had the Liberation War, and today is 25th of March, and this day has a significant role in our life, in every Bangladeshi people's life. Where we are standing, like we are calling us Bangladeshi. It's just because of 25th March, our Liberation War started. On the leadership of the father of the nation, Sheikh Mujibur Rahman, we achieved our victory after 9 months of Liberation War. So my respect to all the martyrs on the Liberation War and everyone who was actively participating at Mukti Yodha, everyone. So thank you everyone, and my gratitude to the father of the nation. And we are actually observing the 50th anniversary of Bangladesh. So thank you all who are listening to me and giving us floor. I was sitting over there and I was thinking that the professors I was hearing their names all through my life. So my life is not that old or not that less, like the young professional just came. So I am a middle-aged woman, and standing here and seeing all my professors here, the greatest minds in Bangladesh, my respected teachers. And I was thinking, what should I say after they have given us the wonderful things which we need to do? Thank you so much, sir, for giving me the opportunity on behalf of the Ministry of Health and Family Welfare. I'm saying something about what the program is doing right now. So most of the things, the treatment, guideline, and everything had actually been discussed in the meantime. But still, I just wanted to say that the prevalence rate of the hepatitis B is 5.5 and adult population, and the hepatitis C is less than 0.6. And we have an achievement that under 5, our prevalence of hepatitis B is less than 0.5. So this is our achievement. And if you go through the SDG goal, they are saying that from 2030, we have to achieve 90%. And we can say that Bangladesh has been actually achieved in hepatitis B. 90% has been achieved in 2020. So this is achievement of Bangladesh, but we still have a long way to go with the surveillance, with the treatment, with the overcome of social stigma, with the overcome of the patients which have misconceptions still now with the hepatitis B and C. So these are what the government is doing now. You know about the routine vaccination. The EPI coverages has been going with the hepatitis B, and this has been wonderfully covered. And our Honorable Prime Minister, Sheikh Hasina, she already got the vaccine hero certification. And this is an honor for us. And Bangladesh actually stood one of the best countries in immunization. And if you see in Corona, the COVID situation, Bangladesh is the 8th country among more than 100 countries in the world in vaccination. We have already covered targeted population, and 12 crore people has been already given the first dose of vaccination. So I can proudly say that Bangladesh is not any less than any country in the health sector, but there are lots of improvement things. So this is one thing we call that our achievement. My fellow colleague, Dr. Tasnia, said that about the adult vaccination. You will be happy to know that the government has already started providing adult vaccination from 2018. And Salimullah Medical College was the first to provide the vaccination among the healthcare people. So by step, we are actually providing all the people who are giving the healthcare and giving the vaccination to everyone. So this is one of our major tasks we are going to achieve by 2030. The treatment of patients with hepatitis B and C, I just have to say one thing, that the medicines which Bangladesh pharmaceutical companies are producing, our sirs are here, they can certify that they are really good, they are really effective. And people of other countries, not Bangladesh and the related countries, but from the UK and Western countries and Eastern countries, they come and buy medicine from our country, and they are cheap and they are quality. So this is another milestone achievement for ourselves. And this is ongoing, and we are trying to improve it every single day. There is the injection safety. Our Professor Sirs, Farooq Sir already said that we are using the AB syringe, and that is for the benefit of our patients. And this has been started not these few years. It started actually from 2003. So this is like not Bangladesh is thinking that, okay, the hepatitis is coming and we are doing it right now. No, we started from 2003 that we are using the AB syringe. Safety of blood and the blood products. We have a program called the Safe Blood Transfusion Program, and it is another program of the DGHS. So this program has been started by the Act of the Parliament on 2002. And this Act has been provided to everyone. And now we have licensed 147 blood banks across the country. And we already collected 7 lakhs, around 8 lakhs of units of blood by 2018. And these are supported by the blood banks. And the screenings are also here. Our learned professors also shared that we are doing the screenings, and it is actually an established procedure through from root level to the tertiary level hospitals. We are actually collaborating with the National STD and AIDS program, because you all know that this is one of the diseases where hepatitis B and C transmitted. So this program is collaborated with us, and we are providing the syringes, we are providing the medicines. Our teacher from BSMMU, sir, is also here, and he knows that we are providing medicines to BSMMU to give the HIV patients and also with the hepatitis B patients. And last but not the least, we have a WASH program where the diarrheal diseases, where the antimicrobial resistance program, and also this hepatitis program, we are working together to combat this viral hepatitis. And I just wanted to say another few words, sir. I'm taking 1 minute from you. So the thing is, we are working on the surveillance. As you all know that not one thing can do the sustainability. Yes, we may achieve it, the elimination by 2030, but we need to make it sustain. For that reason, we have the kits ready for the screening. We have to provide the medicines ready for the patients. And even the patient is less, it can occur anytime. So we have to go through it. A draft of the surveillance plan has been already been here, and we are working with WHO, the costed action plan. So these are the next things we are going to do. And thank you all. This is from me, and I wish we will achieve this elimination process along with SDG, other elimination things which are going to be eliminated by 2030, like malaria, like NTDs. We will be going to achieve this viral hepatitis program also. So thank you all for giving me that.
Thank you, Dr. Khan, for joining us, and thank you for your words of encouragement. So we would like to call our colleagues from London School of Tropical Medicine to the stage. We work collaboratively with them on this project, and we'd like to call them to say a few words on the meeting. So Dan and Joe, I give you the floor.
Thank you, Cynthia. And thank you, Jessica, Cynthia, and Professor Ali for organizing a really, really informative webinar event. And I'd also like to take the opportunity to thank all of the speakers for your excellent presentations. It's been a really great learning session for me, and I'm really impressed by what you have done and what you have been doing and the great achievements that you have made. And I really appreciate your collective and comprehensive efforts, which are super important because to many people affected by hepatitis, your work really means life-changing. So I'm also thankful for this unique opportunity that brings all of us together and me being able to see your fantastic work. And this really is the goal of our Global Open Call, which is to make your advocacy efforts heard and seen more widely, both domestically and globally, so that to inspire us on how to make paradigm shifts on the ground for the benefits of people in need. And to take this further, our London School team is also working with World Hepatitis Alliance to develop a World Hepatitis Summit satellite event, and we're considering a in-person event in Geneva, Switzerland in early June. So we will also arrange digital channels for online involvement. So stay tuned. We really look forward to working with you further along the journey of fighting against viral hepatitis. And I'll stop here the tone for Joseph Tucker.
Thanks, Dr. Wu. I'd like to echo the thanks to all of the organizers, the World Hepatitis Alliance, ZUNAID, the National Foundation. It's really been fantastic to hear all of these expert voices, and it's really inspiring. I think I'd like to I'll be very brief here, but I'd like to say a few remarks about why should we focus so much on hepatitis? Like, what is at stake here? And I think Major General Hussein made a really good point about discrimination and stigma. Hepatitis diagnosis can often mean either the loss of employment, the loss of a livelihood, or a restricted pathway, an alternate future. And I think that's a really important point. And I also, the other talk that resonated, Dr. Tasnia Noor, her community engagement, talking to young people, getting people engaged. I think the future is really bright in this area with hepatitis services and advocacy. There's a lot of unfinished business, and but as Dr. Khan pointed out, a lot of reason for hope that a lot of the policies are in place. The government is committed to achieving these things, increasing vaccination rates among healthcare workers and surgeons. This is a really important issue. And it sounds like there's already agreement that this is should be done. So we also heard about sort of research pipeline and the cutting edge of hepatitis research. hepatitis B cure, we wouldn't have even been thinking about this 5 or 10 years ago, but increasingly drugs for hepatitis B are getting better. And I think it's a whole new world for what hepatitis B therapeutics where therapeutics will take us. And with hepatitis C, thinking about vaccination, I mean, there's really a lot of important research that's being done and opportunities for implementation science and other kinds of research. So again, thanks everyone. I know you are all extremely busy, and it's been fantastic to join you and to hear these exciting talks. And now I'll hand things back over to Cynthia. Over to you.
Thank you, guys. Thank you for speaking and commemorating the National Liver Foundation for holding the meeting. I would also like to echo what Jill and Dan have said. Everyone that has spoken has brought up very good points and very good takeaway key messages on ways in which we can cure hepatitis in Bangladesh. On behalf of WHA, I'd like to thank everyone who spoke, everyone who attended the meeting. I'd like to thank the National Liver Foundation for putting together this meeting in such a short space of time, and with all the resources, using them effectively to have such a great meeting. I enjoyed the meeting very much. Like I said, I've taken away very key messages that I could also use in my work. I'd like to hand over to Jess for her comments as well.
Great, thank you, Cynthia. And I would really like to start by echoing, Cynthia and Joe and Dan, and thanking you all today, all our speakers, especially Dr. Khan, who has joined us, as well as everyone else who's attending and listening. Today's been a really important opportunity to look at each element of the hepatitis response in Bangladesh, as Professor Ali set out in his opening. And, in taking stock of progress to date, we heard about really some of the key milestones that have already happened, including local manufacture of high quality treatment and how hepatitis has been integrated into other areas, as highlighted by Dr. Khan. But we were also able to discuss what work still needs to happen. And I think really what some of the key messages I heard around barriers was that lack of awareness. And I know that the National Liver Foundation of Bangladesh do a lot around this area, and we will continue to support them in that. But a lack of awareness really is a global problem, and it is not unique to Bangladesh, but it's great to see some of the work that Bangladesh is taking to address that. And also cost, that cost continues to be a barrier to people living with viral hepatitis accessing testing and care. The important role of healthcare workers was also highlighted by a number of you, in that this group is really one where we need to target awareness messages at, but also, as Tasnia mentioned, a really important group for prevention activities, including vaccination. And although healthcare workers are really critical, what also came out from today was that everyone has a role to play if elimination is to be reached. And it was clear that all of you in the room are committed to this. And now, finally, we opened the meeting with 2 inspirational videos from people living with viral hepatitis, and heard about the impact of living with hepatitis and being cured from hepatitis had on them. So as we come to the conclusion, I really just want to remind us all that behind every figure is a person living with viral hepatitis. So on that note, I again would just like to thank you all very much, and I will hand over to Professor Ali and the National Liver Foundation of Bangladesh for final thoughts and concluding remarks.
Thank you, everyone. On behalf of the National Liver Foundation of Bangladesh, I'd like to thank all the members engaged with this meeting, particularly members of the World Hepatitis Alliance and London School of Hygiene and Tropical Medicine, and particularly Jessica, Cynthia, Annie, Dan, and Joe, and others. And particularly, I'd like to thank Dr. Afsana Alam Khan from Ministry of Health. She has joined and passed remarkable opinion regarding the status of viral hepatitis control strategies by our government. I am also thankful to Mrs. Muslima Khadir, who also attended here, but physically. What I like to thank for working in this field for long years. It is more than near about 20 years working in the villages and remote areas. I like to think that advocacy is the main pillar for success of the elimination, and that advocacy should be in the locally. Locally means at the grassroots level. Then it will be national level, and of course, advocacy should go in the grassroots level. And advocacy acts as the initiation and maintenance of successful path of elimination, and grassroots activation of the common people, activation of the common people. You must remember that our 65% of our people in the rural areas, 35% in the urban areas. You cannot complete, you cannot finalize, you cannot make any strategy successful, ignoring this 65% people remaining in the village areas. That's why I always make all these programs, and you have seen in our strategy working in the village areas, we have covered most of the districts of Bangladesh. And in Brazil presentation of World Hepatitis Summit 2017, I shown a pyramid of path to elimination, in which it is started with the activation at the grassroots level. If grassroots level peoples in the community, in the local people, in the rural areas, and the mass people get aware about hepatitis B, because most of them don't know what is hepatitis B. They know jaundice and other treatment are there. So if this message of hepatitis B and C will be passed to the grassroots level, then it will be initiated. You will be happy to know that presentation is of elimination pyramid of path to elimination in Brazil, still shown in the novel website of World Hepatitis Alliance. I'm thankful to everybody, and I like to emphasize that there should be a fund allocation for in the national level. Suppose in our government, as Afsana has told, this government is producing fund, a lot of investment is going on. Yes, it should be there. Of course, it should be reinforced to cover all the strategies, and should have a viral hepatitis control strategy in Bangladesh. Every country is coming with a control strategy. We cannot tell exactly Bangladesh whether there is any control strategy or not. Viral hepatitis definite control strategy should be there. The incidence and prevalence of hepatitis B and C in Bangladesh should be exactly known. That is another important. If you don't know incidence, you cannot make any strategy. Strategy depends on incidence. I have got the prevalence of this, and then to control this, eliminate this, I need this strategy. So prevalence should be determined, and then this strategy should be made. Then only we can proceed. And funding, of course, our government is, whatever the means is available, is going to implement the viral hepatitis control strategy in Bangladesh. Needs global funding. You see, if you look into the scenario of HIV, AIDS, malaria, and other diseases which is controlled in the world, a lot of funding there. But what about the funding for the viral hepatitis? Neither globally nor in the country. So if there is no global fund comes out, what came for HIV? What came for malaria identification? What came for other communicable and non-communicable disease control? Fund is coming, global fund is coming in huge amount. What about funding you heard about control of viral hepatitis? So you'll see it is a negligible one. That is the main issue. If you will do something, this finance. And every government, I can say my government is trying hard, whatever means available, but definitely needs global funding, financing, global institutions should come forward. A lot of institutions are there. They are spending a lot of money for a control of other diseases. Why not for viral hepatitis? This question I raise wherever I go, wherever I speak, in the national and international, I raise this issue in Brazil, I raise it in London, everywhere I raise this issue. What about the global funding? HIV can get billions of dollars. Why we are not getting like this? And if I don't get like this, how can I stand there? How can I eliminate? How can I say that yes, we're going to eliminate everything within 8 years? So of course, this is we should pass the message to the global arena, and I'm thankful that WHO is here and the partner that is the London School of Hygiene and Preventive and Tropical Medicine is working in this line, and they will look into this. I again thank WHO and London School of Hygiene and Tropical Medicine for arranging such an August gathering and message meeting with the National Liver Foundation of Bangladesh. Wish success of every effort. Thank you, everybody. Please close.
মোবাইল বন্ধ করে দেবে এটা অফ করে দেবে স্যার ক্যামেরা অফ লিভ দে না স্টপ ভিডিও হ্যাঁ এটা লাগবে না তখন শেষ এন্ড করে স্পিকার দুটো কথা ওইটা কাটো না আসো না
I'm just